Hello, everyone. Dr. Nikhil Verma here with another edition of Things I Didn't Learn in Med School. Today, I want to talk about something interesting that comes up in a lot of my patients, and that is the concept of degenerative disc disease. In my opinion, this is a misnomer. This isn't necessarily a disease more or less than it is a process of how our body naturally gets injured and repairs itself. And over time, those repair mechanisms get less and less efficient based off of how our body changes. So, quite frequently in the pain world, in the interventional pain world, we talk about degenerative disc disease such as arthritis in the back. Now, that in itself is a misnomer because that's not necessarily what happens. It's not an arthritic process, which is a conversation for another day, but it is pretty close to this is normal wear and tear of the body, and this is naturally going to happen over time based off of how our bodies function. This lecture is going to go a little bit more into the weeds of some pathophysiology. It might be over the head of some individuals that are not in the medical field. If you are a patient and you do stick it out to the end, I think you'll find some benefits, especially at the end, or talk about some treatment options that we might have available now and some that are emerging in the future. That, again, is a conversation for a completely another topic, another day to talk about those. But I really want to go through the pathophysiology and kind of what this might look like. For any of you out there that are in this world and have interest in interventional spine or work in the spine industry, I really, really recommend reading this paper right here, The ABCs of the Degenerative Spine. Um, it really breaks down everything for the spine cascade and how our backs tend to degenerate over time and what that looks like. And it talks about some of the pathogenesis and degenerative processes. And I think it's important to get a good grasp on this to know what you're dealing with to see what treatment options we have available in the future. The first point I want to bring up to everybody, what is the spine and what is the functional spinal unit? As you can see here, this is a picture image of a spine cut in half. And we have the vertebrae here. We have the intervertebral disc here, the disc in between the vertebrae. We have the facet joint back here. We have the posterior elements of the spine back here. And as you can see in this image, we have this functional spinal unit as exactly that. The vertebrae, the facet joint, the posterior processes, all combine to make the functional spinal unit. Now, what's not depicted here would be the spinous ligaments, the supraspinous ligaments, the interspinous ligaments, the ligamentum flavum. Also missing is the spinal cord, the spinal column that would come down through this area. And then, again, this is the anterior portion. There's also an anterior longitudinal ligament, and there's a posterior longitudinal ligament that we're not going to discuss here either. My mentors have proposed a different mechanism to explain this. And instead of breaking up into anterior and posterior components, they're actually adding a middle column of that would add in the spinal cord. Topic for another day, but I think that's something interesting to talk about, especially in the interventional spine world, because we do tend to treat either anterior, posterior. Surgeries are usually tended for the middle, though we have some emerging surgeries that are minimally invasive that we actually have some that would treat this middle column for what it's worth. But in the most part, in the world of interventional spine, we are treating the posterior columns, maybe a little bit in the middle column when we're treating with some epidurals. Very, very rarely, based off what insurance allows us to do, we do not treat the anterior columns unless there's a vertebral compression fracture. That is something that we would treat. But again, I implore you to research and look at this article. It does talk about a lot of things, and a lot of things we'll talk about today as well. So if you take that previous image and talk about the vertebrae here, and then we have the disc here, which is made up of the NP, the nucleus pulposus, and the AF, the annular fibers. As you can also see, there's blood vessels invaginating into the vertebral body, but also into the outer rim of the annulus fibers. And then you also see the yellow, the nerve fibers coming into the annulus fibers here as well. As we get older and we have stress on the spine, now this is stress from compression, too much compression up and down, squeezing. This can also be shear stress where we're turning and twisting and bending too much at the spine. You can see that there has a increased blood vessel ingrowth, and there's also increased nerve growth, which could heighten our sense of pain, especially in the sense of when there's inflammation that you can see that happens within the disc. There's calcifications. That's a normal process of pathophysiology. When things are damaged, calcification tends to come in. And you can see more and more blood vessels invaginating into crossing this disc vertebrae interspace and into the disc itself. This is a simplification. Obviously, I'm trying to point out the highlighted points that's important for the talk that I'm giving today. But it's important for us to realize that this is kind of what happens. And this is why we have painful discs over time. Not every disc is painful. I don't have that slide here, but there's a lot of information about even if you have bulging and degenerated discs, does not mean that that necessarily disc is going to be painful for people. One thing that I like to highlight, though, is the annulus fiber. Typically, when we get tears in these annular fibers, it can be severely painful, and it goes underappreciated in a lot of the pain world and the pain textbooks because we don't have treatment options that are covered by insurance for this right now. And they're working on it, and that's again a topic for another day. But I find it super fascinating that we don't have great treatment options for tears in the annulus fibers. And these are all things that we can see on MRI studies. When we do our MRI studies, we can walk our patients through of what we see and why we see it. And if you can make sense of this picture right here with inflammation, you can make sense of what's kind of going on with the degenerative spine cascade. Here is another image of the spine. Now, this is an axial cut where we're going to see this is kind of parallel to the intervertebral disc. Back here is a spinal cord, and then here's the facet joint area back in this area. So, as you can see, the stress I talked about is going to cause proteolysis activation. Proteolysis means they're going to cut up these proteoglycans. These are very, very water-loving molecules in the disc that keep it hydrated and keep it nice and tall. When that stress comes for various reasons, and again, I should say this is a simplification. This isn't exactly how everything works. This is not say all be all, but this is our leading theories based off, and it's more than theories. So we've proven this in petri dishes, and we've proven this in a lot of other cadaver studies, but this is just kind of one of the reasons why the degenerative cascade happens. What's important is the interdisc degeneration, the role of proteases, and the imbalance of the ECM is the extracellular matrix metabolism. When the proteolysis activation comes in, we get a decrease of the homeostasis. It doesn't like to be disturbed. And this causes more to intervertebral disc degeneration. Here are some of the catabolism and anabolism of the spine. I always think of catabolism as catastrophe. It's breaking things down, and the anabolism is more of building things up. And that when this ratio goes off kilter, it will lead to more intervertebral disc degeneration. Now, I'm going to come back to this image because I think it's a little bit easier to talk about some of these things. When we have degenerative disc, a lot of patients ask, like, why did this happen? Why did this happen to me? Well, everything in science breaks down to nature versus nurture. Nature, what was your environment? What was around you? And why did this happen? And then The nurture, how much is it's genetic and genetically predisposed. So we'll talk about the genetic portion. Now, some people do have poor genetics and it predisposes them to I'm not going to say poor genetics that are unfavorable for the health of an intervertebral disc. They have higher inflammatory markers for whatever reason. And these aren't necessarily a genetic factor that would be directly correlated with intervertebral disc degeneration. But what it really is it predisposes you to more inflammation in that area and therefore gives you a higher chance of having degenerative disc. Now, the nature portion is, how much of your environment. One of the biggest things that I always recommend to my patients is smoking and tobacco use and nicotine use, because that will decrease the blood vessels into this area that are going to keep things healthy. Now, these blood vessels, if they're cut off from smoking, tobacco use, and nicotine use, then they're going to get less nutrients to diffuse across this membrane and keep the disc healthy. Now you say, well, if blood vessels are good, then you look at these blood vessels, shouldn't that be a good sign? Well, not necessarily, because these are not healthy blood vessels that are coming up. They are sprouting because they realize there's inflammation and damage, so it's really trying to get there, and it's a very poor and not effective blood supply in that area. So there's again another homeostasis balance of good blood vessels versus bad blood vessels, and it has a lot to do with how much inflammation is in that area. And again, that's a really nuanced topic to get into, but my main point is if these blood vessels are cut off, it's going to cause some bad nutrient drop off to these areas through the capillaries and the smaller vessels. Another thing is work or life stress that's related to that. Again, compressive forces and shear forces. On the same end of that's on the other side of that same coin is a spine that doesn't bend and move is also going to lead to worsening of the degenerative spine cascade. And therefore, we recommend, that's why exercise is so beneficial, because it strengthens this interface. Now, there is a point of diminishing returns. If we could quantify that, I'd be very rich. So we don't know that. So that's why we consistently recommend mild to moderate exercise several times a week in different forms that includes weight training as well as cardiovascular training. That's just a generalized topic to keep or maintain well health, right? Other things, diet is very important. If you're eating an inflammatory diet, it's going to cause more degeneration. There is some theories that are talking about eating foods that are high in anti-inflammatory factors can also help maintain the homeostasis of this disc interface. And there's tons and tons of other things that I'm not mentioning, but these are the highlighted yield points that I talk to my patients about whenever they come in. Moving on to the next thing. So these are some MRI axial cuts of the spine where we talk about grading them based off the radiological findings. And you can see it's called the Modified Fuhrman Grading Scales. This is Viadisc. This is one of the treatment options available for disc degeneration. I don't want to go too much into the details about this company and what they do. Their studies are actually decent, and I actually do like this treatment as an option. Unfortunately, currently, I believe Medicare is the only one that pays for this procedure. I don't know how much it would cost out of pocket. I think it's a great idea. One thing that to look at here is this Fuhrman score is 1 to 8 represents normal disc structure to severe disc degeneration, et cetera, et cetera. So grade 1, that's pretty much normal. Grade 2 is, I would say, pretty much normal. Grade 8 and maybe grade 7, we probably don't want to treat with the intradiscal therapies. Now, I have a theory about that, and I don't want to talk about too much, but really what most people are treating, especially in the studies, are grade 3, 4, 5, 6, maybe 7 for intradiscal therapies. Intradiscal therapy meaning injecting things into the disc. If we go back to this functional spinal unit. Again, I talked about we don't have a lot of treatments to treat the intervertebral disc, either because they're experimental or not covered by insurance. Now, in my fellowship, we did a lot of treatments that were intradiscal. We did a lot of steroid injections into the discs. But the big problem with this was twofold. One, there was a study by Mukherjee, and he talked about if you inject a healthy disc with steroids or with anything, it's going to cause the faster degeneration of the spinal cascade. So if you're grade 3 or 4, you might come back grade 6, 7, or 8 a few years later. What was interesting was this study was mainly done on healthy discs, and it did not talk about already mild to moderately severely degenerative discs, grades 4, 5, 6. But what we know about steroids is that it does cause more degeneration over time, and it decreases your natural inflammatory cascade in that area. So therefore, it would make sense that this would happen. Again, usually 7 and 8 are time we're talking to surgery, maybe an 8 talking about disc replacement or a fusion of some sort. So that's what's interesting about the degenerative cascade of that treatment option. The second bigger issue that we all have concerns about is this disease pathology called discitis. That is infection of the disc. Now, this is a terrible, terrible, terrible condition to have. It requires close surgical monitoring to make sure there's no compression of the spinal nerves. It requires IV antibiotics. It requires lots and lots of follow-ups, and it is painful, 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 painful. I've always seen one case of this in my training that I've had to treat and monitor. Thankfully, the patient is doing much, much better now, but it took him a couple of years to get back to feeling normal. It does happen, and that's why it's a big risk. And we always talk about this anytime we talk to any patient about intravertebral disc treatment options. So again, ViaDisc is one of the treatment options that we have available. In our fellowship, again, we did some treatment options with steroid injections, but with that, we always injected some antibiotics into the disc to decrease the risk of discitis. But we also injected IV antibiotics to really lower the bacterial load throughout the body to make sure that was not going to happen. Even with these precursors, it still can happen. And I think it's a big warning sign to people to have that it can happen. And we should talk about it anytime anyone's interested in having a intravertebral disc treatment option. Now, that brings me to the crux of what I want to talk about. And this is a post that Dr. Centeno, who is Chief Medical Officer at Regenex, one of the leading regenerative medicine facilities in the US, if not the world. He's published tons of papers, and he's always keeping us up to date with the most up-to-date research. And he really, really cares about, hey, what is the best treatment option for our patients? So he made a little list here. If I can open it bigger, I think I can. Let me see if I can. I think I can make this bigger. Just give me 1 second here. Okay, perfect. So you can see the different studies that were done, and there's many citations from PubMed, what was injected, needle technique, and the prevalence, the rate of the infections. You can see here, you can read through these different ones. The two things I want you to be cognizant about is, one, I think anytime it was really a steroid or there was no antibiotics used, the rates were pretty high. You know, 1 in 1,000, 1 in 229, 1 in 642, some intradiscal antibiotics. Um, Here's the biggest study that I saw here, and it had 12,000 plus cases. Um, and they really saw it in 1 in 18,000 discs. And this was steroids with antibiotics. Um, the other thing I want you to keep in mind, and this is something that we're looking more and more into, is how does platelet-rich plasma play into the field? And you had no case in the 47. We still need more and more studies to get anywhere near any powerful study that we actually care about. So, you know, if you do, I would recommend following Chris Centeno if you have interest in this and reading through this and you know, asking him questions about this as well. But I think this is probably the thing that's most important that I want my patients to realize. I want you to realize that you know, really we want to give you a safe number, and I think 1 in 300 is probably a little aggressive, but I think it's a safe number to talk about when we're talking about intradiscal therapies. Now, we're not talking about intradiscal therapies with everything, but maybe intradiscal therapies with steroids. It'll be interesting to see as our studies come out more and more of how our studies show with platelet-rich plasma or stem cells, mesenchymal stem cells, bone marrow aspirate concentrate, or even microfat aspirate, how these treatment options are available. And if we use good techniques. Dr. Penhollow here, she talks about it here. You know, you treat microdose of gentamicin into the disc with a microdose, low concentration of contrast, using bone marrow aspirate concentrate or leukocyte-rich platelet-rich plasma, which has antibacterial properties itself. Use a two-stylated technique. It's a certain technique that we use, and use very important, exceptional sterile prep and drape techniques. 1 to 300, 1 to 400. It's getting a more accurate number in that sense. But, you know, we use every safeguard that we can possibly think of to make sure that that infection rate is as low as possible. But even with all this, it can still happen. Yeah, it'll be interesting. It'll be interesting to see where all of this goes. And I'm a big advocate for these treatments, intradiscal. If it were me, I would probably lean towards leukocyte-rich, platelet-rich plasma or bone marrow because that's where the most study is, with a reputable source of someone that has a low infection rate through their office. It's something important to think about and to have in your wheelhouse. But with that being said, if a patient comes in and looking with a Fearman grade 3, 4, 5, maybe even 6, we have treatment options available where we don't need to treat the disc, and we can still significantly improve your low back pain by treating all the structures and ligaments around ligament structures, nerves around the disc. And we call this an extradiscal functional spinal unit treatment. This is something that's big in our regenerative medicine world and something that we all are looking more and more to. Here's a PRP, platelet-rich plasma, randomized controlled table, also from Dr. Centeno. I'm not going to go through this, but you can see the conclusions and see how well people did over time. So anyways, if you guys found this useful, please let me know. If you have questions, comments, concerns, feel free to send me a message or leave the comments below. You know, intradiscal therapies is something that's fascinated me ever since fellowship, and I want to know how we can get better and improve this and decrease our risk of infections. And I think we have a lot of data, but we need a lot more to get where we want to be and really provide the best exceptional care that we can for our patients. Anyways, if you guys have any other questions, comments, please drop below, and we'll talk to you soon. Take care. Bye.